Diabetes is an epidemic in our country, and yet we have too few specialists, endocrinologists, to go around. We are so thankful that Dr. Manessis from New York is willing to donate his time to democratize access to answers to very real questions from patients who don't have the opportunity to see an endocrinologist on a regular basis. Welcome, Dr. Manessis. Thank you so much for donating your time. And we have more than a dozen questions that have come in this week because you have volunteered to be here to answer all of them.
Thank you so much, Kim. Thank you guys for arranging this, and thank you to all the patients. And we'll try to help as much as I can by answering questions. Thank God I have Jean next to me today, so she's going to be also helping out.
Yes, we have your diabetic educator, and she's also helping out in our network, padsupportgroup.org. PAD, that poor circulation in the legs, is a complication of diabetes. And so Jean is in there helping the patients to know what they need to eat to get their A1C down so that the little sugar molecules don't continue to wreak havoc on the artery walls. So thank you, Jean, and I know she'll probably jump in a little bit later. But I want to start with Douglas. He is the head of our PAD Warrior Task Force, and he says that he is pre-diabetic, and he wants to know some of the risk factors, actually, for diabetes that he should be aware of. What are the options, some of the options you have today of improving type 2 diabetes, and especially at the pre-diabetic stage. And he wonders if there's a set of tools that he should have to monitor this pre-diabetes on a regular basis, and some foods that he should stay away from. So quite the loaded question, but you know, it's standard of what pre-diabetics are asking, and they're not getting the actual guidance from their primary care doctors. Oh, you're pre-diabetic, don't worry about it.
That's actually, you know what? That's the very important question, because we have millions of people in this country who are pre-diabetics. Okay. And probably the majority of them don't even know. So they don't even know what they need to do. Okay. So, and by the time we become diabetic, that's already late. Okay, in the game, because that means we have it probably for 5 years. So pre-diabetes is very critical from a point of view that, you know, until 5-10 years ago, we really didn't have the means of being proactive. Why? Because there was only fasting. We can do only fasting blood tests, and an A1C. A1C is the average marker for glycemic control. And usually people will come in, we will check that, and we'll say, okay, there's really, the A1C is not in diabetic range. You have to take care of your diet. You have to be more active. You have to do, make sure you don't become diabetic. And the other thing we could offer at that time is really metformin, which will delay prediabetes by about 3 to 4 years. Now we have something that it's even more important, I think, because now we can go on a sensor and we can monitor actually the glycemic effect of certain foods that we have. And by doing that, the patients get a more dynamic response to what they're eating, and they're able to see if this raises their sugars, if this doesn't raise their sugars as much. So they can really focus on the diet that really has more beneficial effects in terms of their glycemic control. The only problem we have is, those meters have not been approved for prediabetes. Okay, so they are available. They're available over the counter. People can go and buy them. But you know what? If you're going to eat healthier, you're probably going to spend less money on ordering food. You're probably going to be more proactive. You're really going to be able to have real evidence of the effect of certain meals they have on our diet. And by doing that, you just need a doctor to explain to you how to read those sensors. And when you know what you're reading and how to interpret those sensors, then you actually are good to go. And usually those patients do much better than expected.
And I'm not going to be reading these questions are in no specific order. They're just as they came in. So we will jump around a little bit. Ginger wants to know how much statins can influence the A1C levels.
There is some data that if you are pre-diabetic, there is a specific statin actually that shows that you can get a impairment in your sugar control, so your A1C can go up. but specifically the statins to raise or decrease your A1C in everybody who's on statins, there's no real data about that.
Melissa wants to know, it seems like every month there's a new diabetes or weight loss medication. After everything presented at this year's American Diabetes Association scientific sessions, what developments are you personally most excited about, and which one do you think will have the biggest impact on patients over the next few years? Woo, that was a teeing that
That's
up.
that's definitely so in terms of the ADA, there was definitely a lot of presentation about new medications or new combo peptide medications that really do slightly better job than what we already have. But what I can say right now, whatever combo we use in terms of the A1C, we really have a maximal that we can reach. And that maximal is no matter if you are Ozempic, if you're Mounjaro, or if you are in the new combos that are coming out in the next couple of years, the maximum effect is 2.2%. So that tells us in terms of diabetes, you have a certain ceiling that you can reach with these peptides. In terms of weight loss, yes, definitely we have, we started with Ozempic. Ozempic was causing about 15% weight loss, okay, in non-diabetics. And then we have Mounjaro or tirzepatide. In non-diabetics, we went up to 20%, and now we have a new medication that we can reach up to 30%, which is the triple G. It's called retatrutide.
We do have a couple questions coming in about GLP-1s, actually.
Yes.
We have David. He said, we've heard a lot about GLP-1 medications that don't have the same food and water restrictions as earlier pills. Do you think these newer oral options could help people who are hesitant to start injections and who might be the best candidates actually for these?
So the oral GLP-1s is a alternative to injectables. It's not that they work better or they work less than injectables. A lot of people are fear about injection, because they feel like I'm going to do an injection. But an injection is once a week, okay? So the good thing about injection is you get the medication and you just need to do it every week. Sometimes people forget to do it. Sometimes people miss it. So in that case, an oral medication may be a more easier way to keep up with a daily oral administration. So there's two types of oral medication. One of them is the peptides. The peptides have to be taken on an empty stomach. And there is now a new group of orals that are non-peptides that are replicating the molecular structure of GLP-1. And that can be taken anytime with food or without food. But those ones have restrictions in terms of certain medications that you can take them with.
And Michael seems to have done a little bit of research here. Some of the newest medications, he says, target 3 hormones instead of 1. Can you explain in plain English how these triple agonists differ from today's GLP-1 medications and whether they could become the new standard in care?
Michael, if I can do this in a couple of minutes, I wouldn't be here. But guess what? I'll make it as easy. Single G it's a GLP-1 receptor agonist like Ozempic, okay, like Trulicity, like Badurian. Double G is considered tirzepatide, Mounjaro, okay, because it has a GLP-1 and it has a GIP, which is another peptide that helps mostly with insulin sensitivity. The triple G it's 3 Gs. So we have a GLP-1, we have a GIP, and we have a glucagon effect. The glucagon agonist can help increase your metabolic rate, so that can cause a more additional weight than actually what Mounjaro does, what the double G does. So that's something really, that the company who is producing, who is going to be promoting the GLP-1, they're looking for. They're looking mostly for weight loss because in terms of A1C, they haven't seen significant reduction. But if you can have a medication that can give you even more weight loss and the same A1C as Mounjaro, why not using a triple G? So the more peptides you have, the more effect you get. And what the pharmaceutical companies is, they're looking to figure out what would be the best combo of peptides to be able to get weight loss. Okay, that's important. Good glycemic control, the least side effects, which is an issue, and also benefit the patient's cardiovascularly, or what we call the cardiometabolic renal profile. Because, when you're obese and you're diabetic, you have other diseases like kidneys and liver problems.
Yeah.
So you want to make sure the combo peptide can afford helping you with all those organs.
Yeah, one of the patients, Susan, is asking about some of the other benefits. So, for someone whose A1C is around 7.2%, should the goal always be to push it lower? Are we moving more towards personalized A1C targets, depending on age, heart disease, kidney disease, or other health conditions? And what role will GLP-1s play in all of that?
So, yes, in terms of the A1C, we know the target right now, it's still less than 6.5. The ADA still has less than 7. So with the GLP-1, either a single G, the double G, whatever you want to call them, okay, you can get better numbers than 6.5, okay? Because not only you can get it less than 6.5, but you can also have weight loss and less hypoglycemia than you would do with other regimens. So yes, you have to personalize. Okay, not everybody needs to be less than 6.5. Okay, an 80-year-old person doesn't 7.2. It's perfectly normal. If you have diabetes for years and your A1C is 7.2, you don't really need to go lower, because the
Yeah.
lower you go, the more chances of hypoglycemia, the more chances of having falls, and that can lead to serious accidents. So if you have a very young person, 30 years old, who is diagnosed with type 2, you want to get that A1C as low as possible, because the chronicity of disease in that patient will be for years, maybe decades. So you don't want those patients to develop complications. Now, for patients who have cardiovascular issues, doesn't matter what the A1C. The A1C can be 6, can be 6.5, it can be 7. We still should start them on the medication, because the medication have, especially the GLP-1 based medication, we have data with Ozempic and Wegovy that really benefits them, even if the A1C is normal.
Yeah, with the STRIDE trial, walking
Yes,
is the
that's for
best medicine.
peripheral arterial disease. Absolutely.
And it's helping to improve walking distance. And it's debated as to exactly why, but a lot of it is they're saying that it's the reduction in inflammation that's making the biggest difference
Yeah,
from
increased
the
circulation.
semaglutides. Yeah, which is incredible. Now, Carlos has a fun question with the CGMs, the continuous glucose monitors. He wants to know, with how many years, these have been out, and especially the popularity of them today, is there anything that has come from the data that has really surprised you, surprised anyone else?
I will say, compare, the first sensors came out, actually, where it came out for type 1s. It was in the beginning of 2003, 2004. It was patients who were in a pump. And, one thing I can tell you now, considering to 20 years ago, and Jane can correct me here, is the accuracy of the sensors now compared to what they used to be. Okay. So a lot of people are concerning, they're not accurate, but they have to realize that, when you do finger sticks and you're pricking yourself, you're just checking capillary blood flow, and you're checking a point of care. With sensors, you're checking interstitial glucose, which is the fluid right next to the cells. Okay. And in 95% of the times, it's much more accurate than any finger stick. So, what we see here is the accuracy has definitely improved, and there's special studies that can show that. And we're looking also is to make it more easier for the patients to be able to have a sensor and be able to put, a sensor that doesn't show, so the future lies into providing an implantable type of sensor that will be given to the patients once a year, and will be able to remove and put in, and people would not know that there is a sensor there. Right now, people can see that there is a sensor. They're getting smaller every couple of years. They're getting more accurate. They are easily, Bluetooth and transmitted to your phones, and they last now up to 2 weeks. But that's constantly evolving.
So it's interesting, and I'm not sure where I saw it. I don't know if it's a reality today or if it's something that was futuristic and a promise of the direction the CGMs are going. But I saw it was either a news story or a commercial or something online where the glucose monitor would check the blood sugar. The person using it could um, do a picture of a menu or of something they want to eat. And it would say, hey, in order to maintain this or lower where you're at or whatever it might be, try adding some protein to it, maybe some nuts, or modify it like this, that, or the other thing. Is
So
that
this
today or is
is
that futuristic?
actually today, I can tell you that there is apps where you can take a picture of your food and it can calculate how many carbs you're having.
Right.
Okay. How much protein and how much. I don't know if we have, an app that can direct us how much to have, but I'm pretty sure we're going to have that soon. But right now, we can take pictures and we can provide information to the patients who are eating so they know how much insulin to take.
Mm.
So, and they can do that by picture. Okay. So you don't have to read books. You don't have to learn how to do carb counting. You just put it down and you decide how much carbs you're having. And automatically for type 1s, for example, who require insulin, you can give appropriate amount of insulin based on the amount of carbs. But long term, yes, we will be able to take a picture and decide what percentage of fat is there, what percentage protein is there, percent of carbs, and you know what, we can accumulate that data on a daily basis and figure out if we're eating enough amount of protein, enough amount of carbs, or fat.
Since we're talking about technology, I want to jump to Tom's question because he's talking about AI and he says it's starting to help interpret glucose data, insulin dosing, and even predict highs and lows. How do you see AI changing diabetes care over the next 5 years? And where should patients, this is such a difficult question, where should patients still rely on human judgment? I have heard if you see the debates on LinkedIn, there are some doctors on there that refuse to help any of the companies putting together the AI doc technology because they think it's an ethical problem. But the technology is continuing to advance, so someone's helping them. And that's a fair question. Where should patients rely on human judgment versus AI?
I think they should really start relying on both. Okay, when we interpret sensors, actually AI has been doing this for years. Okay,
Mhm.
but it's very basic. Okay, I have a feeling it's going to become even better, and with together with human judgment and human input, you can, even now we have these downloads of sensor reports that the AI give us an overall correct version, but sometimes they're not so clever yet to give all this little neat information that we can discover by just going deep into the sensor report. And Jean can also help us with that later, how we do that in our patients who are on a pump, for example. So I don't think AI, I think, is going to be, it's helpful. Okay. It's helpful in educating us, educating our patients, help the doctors pick up pick up subtle things that because of timing or because of knowledge base they may not be able.
Yeah.
But I think both the eye and the human input will be critical eventually, and I think you need both. Eventually we're going to need both. We need a hybrid system to be able to do this correctly, because AI does mistakes also. Okay, we see that. Okay, so it's not like because you get it from the internet and you get it from cloud or from Gemini or for whatever, and it's correct. You really need to get, and that's what I tell to my staff. You need to get evidence based. We cannot really go on the web and just start putting information in, and that's not justify, especially medical information.
I always tell people it's only as good as the information that we're inputting into it, and it's never going to be as up to date as a human. Our doctors can't even stay up to date with
We
as
cannot
fast
say
as these
exactly.
clinical trials, right? And so when we're sitting here and let's say I'm on the web all day long, I'm scouring the web for everything that's new and next across the globe. How can I expect someone, a vascular specialist who has been inside the cath lab all day actively treating patients to be up to date on everything that happened today or even this week when they're trying to focus on what's happening right now in front of them? And even AI just can't keep up because there's new information that's being input every single day in so many different places. And AI is trained to go, let's say, to the large universities and to the NIH. But what if the latest clinical evidence is not there? What if it's somewhere else and
And
it's not pointing to it?
the most important thing is where AI is getting their information from. Okay.
Yeah.
Because I have patients coming in and they have gone to any AI system, and I guess some of them actually get the wrong information. So I tell them, you know what, this is more, and I show them there is AI systems that where you can get really good information. Okay, and medically, it's the internet can give you some information, but
Mhm.
it's still vague. So, and it's still, you still have to get a history, you still have to examine the patient, and you still have to put the labs of examination and your history data together to decide about
Yeah.
diagnosis. Okay,
And
that's what I tell them.
we're going to go back to Rachel and talk about prediabetes. She just wants to know, she has, a history of prediabetes in her family. And she says, a lot of people in her family just don't know that they're at risk. At least she says she is aware. So if you do have a strong family history, um, what's the one thing that they should start doing today to prevent it from progressing to type 2 diabetes or even getting the pre-diabetic indication?
Oh, eat a healthy diet, and be active. There's really no secret, nothing else you have to do to prevent or at least to delay diabetes, because genetically, you cannot change genes. Okay, that's what it is. Okay, but diet and exercise and activity, you definitely can change it. So there is people who they have a family history of diabetes and got diagnosed with prediabetes, and they were able to go back into remission by really being very active and eating a healthy diet. That requires a lot of work, but that's the best way of doing it and the best way of really avoiding the need to be on any medications.
Yeah.
I
So
want
I'm
to
going to lead by
add
example here, and I'm going to walk because I want to lead Jean. We're going to talk about exercise and A1C, right? We were talking earlier before this, and you had some really good insight and a question for Dr. Manassis about walking and high A1C.
well, Dr. Manessis, I have been following some Facebook sites, and obviously there's a lot of misinformation. So one of the questions I saw today is that someone who has a blood sugar of 435 and they're only on Mounjaro, they brought it down to 237. So I saw comments like, go for a walk, go for a run. So, what would you consider when the patient with high blood sugar should exercise and when they should not exercise? And what's your advice to them when they're having a high blood sugar?
Okay, so when somebody has high blood sugar, you have to really figure out, is this a chronic effect, or it's happens because you just ate something that's very full in carbs and fat? So if that's a spontaneous elevation of your sugars, yes, you can go out and start walking. Okay. And then as you're burning, pretty much what you're doing is as you're walking, you increase your oxygen carry capacity, you're increasing your muscles, okay, the way they take up glucose, and then your sugars may go down. But if this is chronically, exercising when you are chronically hyperglycemic, as we call it, toxically affected by the high sugars, going and exercise, actually, it's going to make your muscles hurt, and it's not going to be able to bring down your sugars, because in that case, your insulin levels are not working. They're not good. Okay. So in that case, you have to reduce your sugars before you start exercising, because otherwise you're going to go into an anaerobic metabolism and you're going to hurt the next day, and your sugars are not going to come down.
It's almost like catch 22 though, because also walking is the best medicine to prevent peripheral artery disease and to improve symptoms of peripheral artery disease, which we talked about is a complication of diabetes. What is your best advice there? I mean, no matter what, they have to get the blood sugar down first, I guess.
Yeah, it's like if it's chronically hypoglycemia, you really, you have to think about, you are toxically hyperglycemic. It's affecting your blood vessels. It's affecting your nerves. It's affecting everything.
Yeah.
So that's a kind of urgent, it requires an urgency from both the patient and the provider, because sometimes you may need to start the patients on insulin to break that glucose toxicity, because the receptors are used to seeing 400 for a long time. Now, if it's acutely, it's a Friday night, Saturday night, baseline sugars are not perfect, 150s, 180s. And then we go out, we eat pasta, we eat pizza, we have a dessert, because it's Friday night, Saturday night, whatever. And then after that, our sugars, we check our sugars at 400s, then still that's not a good thing. Okay, but then you can consider to exercise and see if you can sensitize and get that food, get your insulin levels work much faster and much more efficient, and to be able to bring it down faster. But that doesn't mean that your sugars will be normal, and it doesn't mean that, your glycemic control is appropriate for any type of cardiovascular disease, including PAD.
Yeah, and just speaking of PAD, so you just talked a little bit, but I always like to ask the direct question the patient has. And Brian is asking how important it is for blood sugar control when it comes to preventing the foot wounds, improving wound healing, and reducing the risk of amputation.
You cannot imagine, how critical it is, because when your sugars are high, think about, I'm going to make it very easy. Even if your circulation is intact in that area, when your sugars are high, your white blood cells do not work well. They don't listen to the issue. They don't get attracted to the site where they need to go and fight the infection. Why? Because the sugars are really covering all the receptors in the cell that helps them mitigate the mediators to drive them to where they need to go to fight the infection. So if your sugars are high, you have intact circulation, the white blood cells cannot fight the infection.
Okay, well, we have Marie that called our Leg Saver hotline today. Her mother-in-law is actually in the hospital in Haiti. So if you know any endocrinologists in Haiti, by any chance, or podiatrists, hint, hint, Dr. Jean Chen, her A1C is over 9. She developed a serious infection, had a TMA a few weeks ago. I'm still waiting to get a hold of the ultrasound. Doesn't seem to be that the artery narrowing is the main issue at this point with the foot going gangrenous. It's because she only seems to, according to the daughter-in-law, has, about 40% to 50% narrowing in various arteries, but nothing 100% occluded. So it drives me to kind of in the direction of the high A1C, at this point, leading to what you were just saying, that, wreaking havoc on the arteries and such, or the smaller vessels possibly. Is that right? She wants to know what questions she should be asking doctors right now. Should she be asking whether her blood sugars are being controlled aggressively enough during the infection, whether they're looking at the source of the infection, to check the kidneys? She has all kinds of questions here.
That's yes, and that's not an easy situation.
No.
If you have somebody who had a TMA, in a hospital, because first we want to make sure after any amputation, and Jane is even knows this better than me, you have to make sure that she has good circulation. Okay,
Yeah.
the
Yeah.
circulation in order for the wound to heal is critical.
But it's
Now,
not
the
just
sugar,
the arteries, it's also the smaller vessels, the collaterals, the capillaries, right? And the
yes, you have
sugar,
to
if it's
form.
high,
You have to make sure they have good capillaries, but also the sugars cannot be high. Absolutely, you cannot have an amputation and your A1C be above 9 and 10 and expect it to heal. It's not going to heal. Okay, but so you need to be on insulin. You need to get the sugars under better control, and you
okay,
need to hope that there's good circulation. And there's ways of checking the circulation with a Doppler, okay, inside the hospital,
yeah.
and see if there is good distal pulses. Okay, because if it's not good distal pulses, it's not going to heal. Of course, it needs also good wound care. Is that the right, Gene?
Absolutely. Wound care is very important. And one of the questions I will be asking is when they did the transmetatarsal amputation, was there any bone involved in infection? And was all the infected bone removed? Because if there's still infected bone, that wound is not going to heal as long as there's infection going on. So does that
Yeah.
mean if a patient has still some osteomyelitis, which is bone infection, will they be on IV antibiotics or oral antibiotics, and for how long? And who's going to do the follow-up? Is infectious disease involved? Is vascular involved? And is there a wound care specialist who can be available to do advanced wound care?
That's an excellent point, Gene.
Yep.
The bone infection is critical. So you can have good blood flow, guys, and still get an amputation.
Yeah.
Okay, if you have bad neuropathy, if you had a trauma, okay, and you have bad neuropathy and you can feel that it was really forming and wound there, okay, and you can get gangrenous toes or gangrene food with normal circulation.
Yeah, she was calling because she wondered if she should fly her out here to the States. And I said, well, you can always make that choice if she's healthy enough and can make the flight.
If it's stable
But
enough, yes.
the thing is that if it's not a vascular problem with the arteries, and it's a situation where it is purely the A1C that's causing the issue, is it worth the risk of the flight and coming out here to the States when blood sugar can typically be managed? I would think most places in the world she is getting insulin.
You know what? I would stabilize her glycemic control, make sure she is stable hemodynamically, she's not bleeding from the wound,
Yep.
and then I will consider that. Yes.
Yeah.
And if she can switch on oral medications, then she can consider get her here for a second opinion.
Yeah, we're going to send her to you in New York. Both you and Jean can take over.
Not about yes.
We have one more question that we have here that we haven't gotten to. Jennifer is asking about preserving beta cell function instead of simply treating high blood sugar after it develops. Are we getting closer to therapies that actually change the course of diabetes rather than just managing it?
Yeah, we're getting closer. We're getting closer in using medications to help us preserve beta cells. But right now, those medications are really immunosuppressive therapy that targets a single pathway. So there's a bunch of different pathways they're looking into it. So right now we have one medication that's approved to delay type 1 diabetes and early type 1. And there is also an approval, but still research needs to be done for using early type 1, meaning full-blown type 1. And they have it for less than 3 months, which we can give them a medication and delay the progression of the disease by about 3-4 years. But again, this is still experimental.
Fantastic. Thank you so much, Dr. Manessis. Anything that you want to share that's been top of mind for you as we close out today? Final pieces of advice, any hope that we can provide for folks for the future of diabetes care?
In terms of the future diabetes care, in the management of a type 2 field, okay, I think we might be doing a little bit better than we used to do 5 or even 10 years ago because of the new classes of medications and how aggressive we are about that. Hopefully, if we deal better with the obesity epidemic, I think we're going to be able to deal better also with the management of type 2 diabetes because I'm very, I really feel like we have to do better in terms of our diet and our lifestyle. We have to be more active. Okay. It will be nice if we can prevent diabetes instead of treating it. By preventing diabetes, we'll eliminate also what? Insulin resistance, the metabolic syndrome, whatever the effects they have in all our organs, and will definitely prevent micro and macrovascular complications.
And by the hair of our Judy Chin Chin, one more question coming in from Clarence asking about fasting. Hearing that fasting is essential for our fight against insulin sensitivity. It's being suggested to strive for 16 hours minimum. What do you think about fasting and insulin sensitivity?
Okay, that's actually one of the best questions tonight because there's a lot of things being told in the internet, in the web, Instagram, but 16 hours fasting is not really the way to go because don't forget, if you don't feeding your metabolism, you're not going to be able to get your diabetes under control. You're not going to be able to get your sugars under control, and you're definitely not going to be able to lose weight. So the idea of fasting, intermittent fasting, is based on the following. What we do in life usually is we go home 5, 6 o'clock after work, and then we eat at 7, and then we'll go to bed. So that late dinner is really gets stuck in our belly all night. That causes the insulin levels to go high, and that causes a lot of problems regarding our metabolic parameters. Now, the fasting was thought to be an idea that you don't need anything after 6, 7 o'clock, and then you get up in the morning and you have, you start with a breakfast and then you go on. That was the idea behind intermittent fasting. It was not intended. And there's really no data that supports that if you eat more, if you don't eat for more than 8, 7 hours, that you're going to have that you're going to do better. So why? Because the more you fast, the more likely you're going to eat. You're going to have higher cravings because of your insulin resistance, and that's most likely it's going to cause what? It's going to cause you to eat more when you eat. Okay, even if you eat 1, 2 meals a day. So small meals, intermittent meals, high protein, less carb, less fat. It's much more efficient than any type of fasting. Okay, that's what I think we should think about it. And yes, don't eat a bedtime snack full of carbs 10 o'clock before you go to sleep because your insulin level is going to go high. And guess what? You're going to absorb everything you have there.
So since you had mentioned the Instagram and some of the social media stuff out there, I can't leave this discussion without asking you about the latest TikTok trend where everyone's jumping around for 15 minutes to bring their insulin levels down after eating. Have you seen those? Jean, have you seen those?
I have not seen that.
I'm not on TikTok.
So the new thing is you jump for 15 minutes or something after you eat, and voila, your insulin levels are normal and you don't have to worry about diabetes.
Okay, so I don't know. I need some data they need to show me how 15 minutes can help that. Okay, when we're talking about walking after dinner, okay, we're not talking walking for 10, 15 minutes or jumping we're talking to take an hour walk around the neighborhood with your dog or without your dog, with your partner, and really have a nice, enjoying walk, discussing things, and don't feel like you have to do something very aggressive like what you are discussing now, Kim. I really feel like this is all, everybody has something to say, and everybody makes it sound like in TikTok that it's really the treatment for everything.
I know. And just because they have a DR period in front of their name doesn't make them a practicing physician and right when it comes to a treatment for you. Everyone is looking for clickbait. Everyone is taking clinical evidence out of context in order to drive views and likes and comments to become internet famous. So really be careful. You can take a lot of what you see and make sure that you make an appointment with your doctor to have the discussion to ensure that the information is accurate and right for your presentation of disease. Thank you so much, Dr. Manessis, for joining us. Thank you so much, Dr. Jean Chen. We really appreciate you guys being here, and hopefully we'll have you back next month. We love these monthly discussions. So many questions coming in, and I think it's such a service to so many who don't have access to an endocrinologist. For those watching, make sure you like this video, subscribe to our channel for more great content like this. And if you have questions for Dr. Manessis or Dr. Jean Chen, make sure to email us at info@padhelp.org.